Hello everybody, my name is Chirag Patel. I'm one of the Gastroenterology Fellows from Oklahoma State University. Today I'm going to present my journal club topic on steroid-free deep remission at 1 year does not prevent Crohn's disease progression. Crohn's disease therapeutic goals have shifted from symptomatic control to achieving clinical and endoscopic remission off steroids. Data regarding long-term impact on achieving an early deep remission on Crohn's disease history remains scarce. Patients with Crohn's disease included in the TAILORIX trial were started on infliximab in combination with an immunosuppressant for 1 year. The aim of this study was to determine the long-term impact of achieving clinical and endoscopic remission on disease progression in Crohn's disease patients. The TAILORIX trial was a randomized double-blind controlled study performed at 27 centers from July 2012 to September 2015. The aim of that study was to determine if proactive therapeutic drug monitoring would lead to higher clinical and endoscopic remission rates compared with pure symptom-based dose adaptations. The included patients in this study were biologic-naive adults with active, uncomplicated luminal Crohn's disease with visible endoscopic ulcers having an indication to start anti-TNF therapy. Excluded patients were patients with contraindications to anti-TNF agents or immunosuppressants or other serious concomitant diseases. The primary endpoint of the study was to evaluate for corticosteroid-free remission at all visits between weeks 22 and 54 with associated absence of ulcers on ileocolonoscopy. Endoscopic activity was evaluated via the simple endoscopic score for Crohn's disease. All patients randomized in the TAILORIX trial were eligible, and patients with an absence of follow-up data since the end of the original TAILORIX trial were not included in the present study. The patients were divided into two groups if they reached the TAILORIX primary endpoint or not, and outcomes of both groups were compared. The primary outcome of the present study was to compare rates of progression-free survival in the two groups. Crohn's disease progression was defined by the occurrence of the first following event during the follow-up period, which was major abdominal surgery, anal surgery, hospitalization, or the need for new systemic Crohn's disease treatment. Moving on to the results section, out of 122 patients, 27 were lost to follow-up, 95 were included in the TAILORIX long-term study, and 45 patients reached the primary endpoint while 50 did not reach the primary endpoint. At the end of the follow-up, 13 patients underwent luminal surgery, 9 underwent anal surgery, 22 underwent hospitalization, and 32 underwent new Crohn's disease treatment. This is a table showing the mean CDAI score was lower in the 45 patients who achieved the primary endpoint of the trial than in the 50 patients who did not, while the mean CRP level, fecal calprotectin level, and SES-CD scores at week 54 were not significantly different. Progression-free survival rates were similar in patients who achieved the TAILORIX primary endpoint compared to those who did not, and patients with complete mucosal healing also had similar progression-free survival rates to patients with a SES-CD of 1 or higher. And this is a survival curve of Crohn's disease progression-free survival in patients who reached and did not reach the TAILORIX primary endpoint of sustained corticosteroid-free remission. You can see that the graphs are similar in this survival curve. This is a survival curve of patients with Crohn's disease progression-free survival with complete mucosal healing versus an SES-CD score of 1 or greater, and you can see that it was not significantly different between the two groups. These are different survival curves showing the different survival rates amongst patients without major abdominal surgeries in Figure A, without anal surgeries in Figure B, without hospitalizations in Figure C, and without new Crohn's disease treatment in Figure D, who have reached steroid-free deep remission versus absence of steroid-free deep remission at 1 year. These graphs show that they are not significantly different. The limitations were that the follow-up data were collected retrospectively and the sample size could not be changed because the present study was based off the previous TAILORIX trial. The prediction of follow-up evaluation was based on a single endoscopic assessment. The strengths were that the present cohort of biologic-naive adults included in the prospective clinical trial was well characterized and homogeneous. Ileocolonoscopies performed at week 54 were read centrally, and follow-up data collected in 78% of the patients were robust, including hospitalizations and surgeries with limited risk of evaluation bias. In conclusion, neither the association of clinical and endoscopic remission nor complete mucosal healing were associated with better disease outcomes, and early use of powerful treatments to modify the history of Crohn's disease and suggest that a more flexible approach of the treat-to-target concept should be taken in daily practice. And these are my references. Thank you everybody for listening. I want to give a special thanks to Dr. Ali, Tina, and the SAIA organization IBDCLUB for allowing me this opportunity.